Hi guys, can you guys hear me? I'm just gonna wait until 7:30 until a couple more people join.
I needed a strong cup of coffee because mom's coffee wasn't that strong this morning.
If you guys could just make sure that your microphones are muted before we start, otherwise the noise in the background will be really distracting. I'm gonna get started in a couple minutes when a few more people join. I'm just waiting until 7:30 so everyone has a chance to log on.
Sure about it, okay?
Okay guys, I'm gonna get started. And Amber, your mic is muted. Yeah, I can't hear you, so thank you for that. I just want to make sure that you guys can hear me because if people are talking in the background, it's going to be really hard to hear over the background noise. But I do want you guys to participate. And actually, the first thing that I want to do is kind of like just opening up and asking what you guys hope to learn from this workshop. So I'm going to share screen. And if you guys can just type in, you can log onto this website. If you go to paulev.com, I'll show you in a second when I share screen. And then you can actually type in the responses to this question that I'm going to share with you. So let me just share screen. Are you guys able to see this? You have to use your microphone to talk because I can't see the text box since I'm share screening. But if you go to Paulev...
Yeah, we can hear it.
Okay, can you see the screen?
Yeah, I see the screen.
You can either go to the website and type in your responses, or you can just talk. If there's anything that you guys hope to learn in this workshop, you can just talk with your microphones if that's easier. Is there any subjects that you guys feel uncomfortable with? Anything that you're struggling with, like labs or specific body systems that you're struggling with? Is it study skills that you need help with? Time management, maybe? Anything that you guys hope to learn? Anybody? I see some people typing, so I'll wait. Study skills, okay. Any tips, tricks for approaching breaking down questions? Victoria, we're going to do some questions together. I think that'll help you. Anybody else have anything that they'd like to focus on? Question breakdown. Okay,
Hello.
perfect. Hi, Geraldine. Who's talking? I'm sorry.
Oh,
Kirsten.
Yes. So the chapters that we have the most questions from are musculoskeletal, neurological system, female and male, genitourinary. Those are the chapters that have the most questions on the test according to professors, followed by cardiac and respiratory.
Okay, so for this study session, we're actually focusing on respiratory. Because we only have 2 hours, we had to kind of condense and pick which chapters the professors want us to focus on. And after speaking with Dr. Rollins and Dr. Collins, my supervisor and your professors decided respiratory was the chapters that we're going to focus on for today. We're going to do ABG interpretation and do some questions at the end. And we're going to do a little bit of A&P review for respiratory. So I know that you guys have a lot to study, but at least this will be one less thing, hopefully, that you'll have to study for the exam, because we're going to do this review.
Okay, perfect.
Okay, all right, great. So I'm going to get started. And like I said, the first thing that I want to focus on is the just a quick A&P review, because understanding the anatomy and physiology of this will really help you going forward when you're assessing your patients. You have to understand the A&P before anything. So we're going to go through the thorax and lungs very quickly, because I know we have a limited amount of time. But this first part here is talking about the thoracic cage. And the thoracic cage is a bony structure with a conical shape, narrow at the top. Defined by the sternum, there's 12 pairs of ribs and 12 thoracic vertebrae. The first 7 ribs attach the sternum by costal cartilages, and 8, 9, and 10 attach the costal cartilage above. 11 and 12 are floating with free palpable tips. This is just talking about the anterior part of the thoracic cage, the sternum, which is probably the most important part to focus on. It's composed of 3 parts: the manubrium, body, and exophoid process. So this is just a picture that's showing exactly what we talked about. The sternum is in the middle. Across the top here are the clavicles, and in between the clavicles, you could actually feel this on yourselves. There's a little indentation called the suprasternal notch. Okay? The manubrium is the first part. The sternal angle separates the manubrium from the body, and then the exophoid process is this pointy little part at the bottom. And again, the 12 pairs of ribs 1 through 7 attached to the costal cartilages, and then 8 through 10 attached to the costal cartilages above it, and 11 and 12 ribs are free floating. This is just talking about the posterior thoracic landmarks. You have the vertebrae prominence, spinous processes, inferior border of the scapula, and the 12th rib. And again, another picture of the posterior thoracic cage. Okay, I'm just going to kind of quickly go through this because I want to focus on the assessment part a little bit, but this is just a refresher for you guys. And this is talking about reference lines. So for example, when you guys are working as nurses, maybe you have to do an EKG on the patient. These are reference lines that you can use to perhaps place an EKG or talk about a specific part of the body. These are things that you can use to refer. So most importantly is the midclavicular line, and that's right in between the clavicle, in the middle part of the clavicle. The midsternum, the sternum again is in the middle, so this is the midsternal line. And the axillary is armpit, so this is the anterior axillary line, right at the armpit. This is the posterior reference lines. The vertebrae are obviously in the middle, so this is the vertebral line. The scapula are on the sides here, so this is the line that's cutting the scapula in half, and that's right there. Lateral reference lines. Okay, so this is just kind of separating the axillary into 3 parts: mid-axillary, anterior, and posterior. So this is just another thing that you can use to reference different body parts or anatomical locations in the thoracic cavity. Okay, so the lobes of the lungs. The lungs are paired, but they're not symmetric. The right lung is actually shorter than the left because the liver is on the right side of the abdominal cavity, and that's what causes the right lung to be a little bit shorter. The left lung is narrower because of the heart and the heart bulges a little bit to the left, so it causes the left lung to be narrow. The right lung has 3 lobes, and the left lung has 2 lobes. And the way that you can remember how many lobes is by left has less. The left side has less lobes. Okay. This is again talking about the lobes of the lung. The left lung has no middle lobe. Okay, so remember, left has less. And if you were to assess your patients, the best way that you can do that, let's say you want to listen to their lower lobes, the best position for your patients to be in would be to assess them from the back, from the posterior chest wall, because the backside has mostly all lower lobes. This slide is just discussing the pleura. So there's pleural cavity, which normally has a vacuum or negative chest or negative pressure, and it holds the lungs tightly against the chest wall. The pleural cavity is a space filled with only a few mLs of lubricating fluid. There's actually 3 parts. There's the visceral pleura, which lines the outside of the lungs, and then there's the parietal pleura, which lines the chest wall cavity. And in between the visceral and the parietal pleura is the pleural cavity, which has that lubricated fluid, so that way when the lungs expand, those layers of the lungs are not rubbing against each other. It prevents friction. Okay, and this is talking about the trachea and the bronchial tree. The trachea lies anterior to the esophagus, and it separates into the right and left main bronchi. The right main bronchus is shorter and wider and more vertical than the left main bronchi. And the trachea and bronchi transport gases between the environment and the lung parenchyma. They constitute dead space, or space that is filled with air that is not available for gaseous exchange. And this is about 150 mLs in the adult. Okay, and I just want to mention, as you go farther down the bronchi, they get smaller and smaller until they reach the alveoli. And the alveoli are these grape-like sacs where the gas exchange is actually occurring. Okay, so you start with the trachea, separates into the right and left main bronchi, and then those bronchi break off into primary, secondary, and tertiary bronchi. So they're getting smaller and smaller as they go on, and eventually break off into alveoli. And the alveoli are those little sacs where the gas exchange is occurring. There are 4 major functions of the respiratory system: to supply oxygen, remove carbon dioxide, and maintain acid-base balance, which is what we're going to talk about in a little bit with the ABG interpretation. But by supplying oxygen to the blood, our lungs are able to breathe in the O2 and eliminate the excess CO2. Okay, and that is what, through that respiration, is what maintains our pH or acid-base balance. This is kind of just a picture which shows what we already talked about: the trachea, which are then separating into the right and left bronchi, and then getting smaller and smaller until they make up the alveoli. Okay, so this is talking about the control of respirations. Normal stimulus for us to breathe is an increase in carbon dioxide, or hypercapnia. Does anyone know what the normal CO2 level should be in our blood? You can either type it, or you can just talk. Exactly, yep, 35 to 45. Yeah, good. So what's hypercapnia? What would the CO2 level be if they have hypercapnia? Right, greater than 45. Anything above 45. Good. So for us, hypercapnia, if we have high CO2 levels in our body, that's the stimulus for us to breathe. Okay? And the decrease of oxygen, or what's that called? A decrease in oxygen. Hypoxia, yes. Hypoxia. And the decrease of oxygen in the blood, hypoxia, also increases respirations, but it's less effective than hypercapnia. Okay? This is talking about what's going on with the mechanics of respiration, the muscles that are involved, the AP diameter or the anterior posterior diameter of the chest wall will increase with inspiration and decrease with respiration. With inspiration, the external intercostal muscles will go up and elevate the ribs, and the diaphragm will descend as the lungs take in that air. So there will be an increased vertical diameter. Okay. So that's the end of the A&P. I'm just going to go ahead and get started on the health assessment part. Okay, so some things that you might want to assess subjectively, and what does subjective mean? Can anybody tell me what would be, for an example, a subjective assessment? Patient tells you, right? It's not something that we can exactly measure. For example, pain, right? Pain is a subjective assessment because that's something that we can't, we have to trust what the patient is telling us. It's something that the patient themselves is feeling, right? So what questions might you ask to assess? Let's say we're doing a respiratory assessment. The patient has a cough. They're complaining of a cough, and this is a subjective assessment. What are some things that we might be able to ask the patient to assess this cough? We're going to start, is it productive, right? And what does productive mean? Sputum. Productive means is there sputum, and non-productive means there's no sputum. So that's right. You would want to see, are they coughing up sputum? What color is the sputum? Is it yellow, which might indicate an infection, or green, which might indicate an infection? Is it pink and frothy, which might show heart failure? Good. Is it better in the morning, same, or worse? Have you done anything to alleviate the cough? Has it helped? Good. Good. Those are all exactly what you would want to ask your patient. So let's go through these. How long have you had the cough, right? Is it something that's new? And if it's acute or new, it would last less than 2 to 3 weeks. If it's chronic, it's considered lasting over 2 months. So you want to assess the length of the cough. What time of the day does the cough arise, which I think a few of you mentioned. Is it worse in the morning time? Is it worse at nighttime? The sputum production. Is there blood with the sputum or hemoptysis? And then you want to ask them to describe the cough. Is it dry? Is it hacking? Is it congested? Is it productive? Like we said, is there sputum coming up? Is it non-productive? And treatment for the cough. Are they taking anything over the counter? Or do they need to rest more than usual? Are they using humidification? And the severity. Are they having chest pain with the cough? Are they more tired than usual? So good. Those are all subjective things that you want to ask your patient to assess their complaint of coughing. So why would we want to assess the timing of the cough? Can anyone think of any rationales why the timing would be important to assess in our patients? Right? Exposure to an irritant, that's true. If they happen to have the cough, let's say they went to school and the ventilation in school is not good and they're breathing in a lot of dust and debris, perhaps that after school this student is having a worse cough after they get home from school because they're exposed to irritants in the school place. Right. If it's nighttime sleeping and fluid moves into the lungs or laying down, right? Because what happens when we're laying down? All the blood in our legs is going to return to the heart, right? There's going to be an increased venous return to the heart. So it's going to be harder for someone with CHF when they're laying down flat to be able to pump out that blood when they're laying down. And what's that condition called when they have shortness of breath when they're laying flat? Yes, orthopnea. Okay, good. Mucus buildup in the morning, exactly. So a dry cough that is continuous throughout the day might indicate a respiratory infection. Someone had mentioned if it occurs at the end of a school or workday, they might be breathing in something from the environments, from environmental exposure, for example, dust or mold. Maybe they're a coal miner, you know, you have to think about also the occupations that the patient might have. A nighttime cough might indicate postnasal drip or sinusitis. And an early morning cough is usually a complaint of people who are chronic smokers. Okay, good. Oh, wait, I didn't key that too. Okay. Color of mosquito. So if it's yellow or green, it might indicate a bacterial infection. I think we mentioned this already. If it's rust or rusty, it might indicate tuberculosis. And pink and frothy sputum is commonly seen in heart failure. So these are all reasons why we want to ask these questions to our patient to see what's going on with them, to see the color, timing of the cough. And some conditions have a characteristic cough. For example, mycoplasma pneumonia has a very characteristic hackney cough. Croup has a characteristic barking cough. Okay, so these are all important questions to ask when you're assessing your patient's cough. Shortness of breath. So how do we assess shortness of breath in the patient while we're doing a subjective assessment? What are some things that we could ask?
I'm sorry, can you repeat what you just said? What can you ask about what? I missed what you said, I'm sorry.
That's okay. I asked what are some things that we can ask our patient when they're complaining of shortness of breath? Is it on exertion? Is it on exertion or is it at rest? Is it new? Yep, that's important, right? Because we want to know, is this a chronic, let's say they have COPD, they're chronically short of breath, or is it new and they're, breathing very quickly and they have sudden onset chest pain? These are things that we want to know so that we can start to intervene. Any other associated symptoms? Exactly, right? Good. So we're going to assess the characteristics of the dyspnea. Is it acute or chronic? And chronic is defined as being greater than 1 minute. And the severity, is it really bad, or is it able to resolve on its own, right? Is there wheezing? What other associated symptoms, which Kirsten just mentioned? Is there wheezing? Do they have cyanosis or blue discoloration of the lips? Do they have night sweats or fever that occurred with the dyspnea? And what might night sweats and fever along with shortness of breath be indicative of? TB, right? Because with TB, patients they'll have dyspnea, they'll have fevers, and they'll have night sweats, right? So that might be something that a patient with TB might be complaining of. Is it positional? Do you need extra pillows at night? And how many, right? We already talked about the orthopnea. And the orthopnea occurring because of the increased venous return to the heart. All the blood that's normally in the legs returns to the heart. Okay, so we might see this in patients with heart failure needing extra pillows at night. And how many pillows? That's another important question to ask. When does it occur? How long is it lasting? Is it occurring when you go up a flight of stairs? Is it occurring with exercise? Is it exercise induced? Is it occurring, like we said, after school or after work? Does it occur with exposure to certain agents? Sometimes also perfume, right? So people are really sensitive to perfume, and that might trigger an asthmatic reaction. Heat is another thing that, especially today, right? A lot of probably people coming into the ER with asthma exacerbations from the heat, or with exercise. There's exercise-induced asthma. So these are all things that we can also ask to assess the shortness of breath in our patients. And what relieves it? What is the patient doing to relieve the dyspnea? Are they using corticosteroids, inhalers? Do they need oxygen? Right? Is it getting better or is it getting worse? And what's what vital sign, what would we use to assess the oxygen? Pulse ox, right? Yes, SpO2. And what should the SpO2 be greater than? Usually 92. 92 is okay. You want them greater than 92. What if they have COPD though? You might not want a patient with COPD to be on oxygen and to be saturated that high, because patients with COPD, their drive to breathe is the low carbon dioxide. So patients with COPD, we might actually want them to be around 89 or 90. Because if they become, we don't want to make them to become dependent on oxygen. Because as we give them the oxygen, it will decrease their drive to breathe. Does that make sense? Okay, and the last thing we want to assess with shortness of breath is the effects that the shortness of breath is having on their ADLs. I said patients with COPD, it's okay for patients with COPD for them to be satting a little bit lower, because their drive to breathe is the high CO2 levels. So if we give them oxygen, it's decreasing their drive to breathe. So if we see that we have a patient with COPD on oxygen and they're satting 95, you might actually want to take off that oxygen, because we don't want them to be satting too high. It would be okay for a patient with COPD to be hanging around 90, 91, even 89 sometimes. Okay, so let's move on to chest pain. How can you assess chest pain? What are some things that you would ask your patient to assess their chest pain? Ask the patient when it started, if anything happened first, exertion, is it radiating anything anywhere, where the chest pain is occurring, good. Is it activity induced? Describe the pain and the severity, good. Good, yes. What were you doing when it started, right? So we want to ask the patients to point to the exact location, right? And why is that important? Why is the location of chest pain important? Yes, exactly, Kirsten. It's important because we want to assess the underlying conditions, right? We want to see if it's truly cardiac in nature, or is it a result of something else? Good. So we want to ask the patient, is it right-sided or is it left-sided? And ask them to point to the exact area. So it shows issues with GERD, right? That's another, instead of being chest pain or cardiac in nature, it might be epigastric pain from GERD, exactly. So instead of being right or left, it might be mid-epigastric, and they're confusing that with chest pain, right? Another thing you want to ask is the time frame. When did it start? Is it constant? Does it resolve? Is it radiating? Chest pain that is truly cardiac in nature may have left-sided chest pain that is radiating to the jaw, shoulder. And you want to ask them to describe the pain. Is it burning? Is it tight? Is it stabbing? Right? Patients with asthma, for example, they might have chest tightness, but that might not be cardiac chest pain. It's from the bronchoconstriction in their lungs that's causing the chest tightness. Right? And what causes it? Is it brought on by exertion, by coughing, by infection? When they take a deep breath, are they having chest pain? And when patients take a deep breath and they're having chest pain, what might that indicate? They're irritation of the trachea, okay? Or PE, right? The patients take a deep breath and they're having pain, that might be symptom of PE. And then you want to ask them about their treatment approach. What have you done to treat it? Yes, Maya, PE, yep. Remember, pain with deep breath could signal a PE. What have you done to treat it? For example, are they taking any medications for the pain? Have they put heat on it? Are they taking nitroglycerin, and did that relieve the chest pain? Because anginal chest pain will be relieved by nitroglycerin. And what is nitroglycerin? Do you guys know? What kind of medication is that? Vasodilator, right? Exactly. So if a patient has chest pain and it's cardiac in nature, and they're saying, oh, I took nitroglycerin to relieve my chest pain, then you would know, okay, this might be a cardiac issue, underlying cardiac issue. What does the vasodilator do? What's the action of vasodilators? Right. Right. It dilates the blood vessels. It decreases the workload of the heart, and the oxygen increases the oxygen in the blood supply to the heart. Exactly. Good. Okay, so now we're going to assess their smoking history. So what are some questions that we can ask to assess the patient's history of smoking? How many packs a day, right? That's a big one. Yes, exactly. What other things, there's other things now that they could be doing. They might be vaping, they might be using tobacco, so there's other nicotine products that they might be using as well. How long have they been smoking? E-cigarettes, right? I think those have like more cigarettes in it than a regular cigarette. How long have they been smoking? How many packs a day? Age started? Have they tried quitting? Good, yes. So let's go through this. Do you smoke cigarettes, cigars, vape, right? At what age? How many packs per day? How long did you smoke? Have you tried to quit? What have you done to try and quit? And do you associate other activities with smoking? Okay, so those are all things that we can use to assess our patient's smoking history. Environmental exposure, right? We kind of discussed this a little bit earlier. Are there any triggers that affect your breathing? What are some of those triggers? Let's say your patient has asthma. What are some triggers that might flare up an asthma attack? Allergies, exercise, allergens. Good. So you want to ask, are there any triggers that affect your breathing? For example, do you have allergies? Did you just exercise? What symptoms do you have? Are they wheezing? Are they in a tripod position, perhaps? Are they using accessory muscles to breathe? Are their lips blue? Things like that. And where are they working or living? What are their work or living conditions like? Is there poor ventilation? Is there a lot of dust? Things that might trigger an asthmatic episode. Let's see. What are they doing to manage the condition? Are they using inhalers? Have they been using their rescue inhaler more frequently? Does their therapy need to be stepped up, right? Maybe they need to not only have an inhaler, but have nebulizer treatments, for example. And has that management been effective? And how are they having their asthma examined? Are they going to get pulmonary function tested? Do they have periodic examinations? Do they even have a pulmonologist that they're following up with? These are things that you want to ask so that you can educate your patient and perhaps get them the resources that they might need. Why else do we want to assess their smoking history? What does smoking put them at risk for? emphysema, COPD, right? What else? Cardiovascular event, stroke, good. Lung cancer too, right? Lung cancer. Atherosclerosis, PVD, exactly, good. And what do we want to encourage? We want to encourage what? Smoking cessation. Do you guys have any ways that we can encourage that for our patient, or have any ideas that we can help, any things that we can do to help our patients quit? What else might we want to assess? Exactly, Kirsten, the readiness to quit. Maybe we can help them quit by modifying the behaviors that they associate with smoking. Remember, we asked that question back here. I think it's here actually. What activities do you associate with smoking? Let's say the patient associates drinking with smoking. Maybe if we modify some of those other behaviors, we can help them to cut back on their cigarettes. And we also have to ask them, right, Kirsten, what is their support system like? Also want to ask them how many cigarettes that they're smoking a day. Maybe it's not realistic for this patient to stop smoking completely, but if they can start to cut back, maybe go from 5 to 3 and then from 3 to 2 and do it gradually over time. What are some other medications that these patients can be prescribed? Gum, exactly, nicotine patches or gum. Exactly. Good. So by assessing those self-care measures, that's how we can educate on ways, the ways that the patient can reduce their risk of developing cancer, or we were talking about asthma, we can also educate them on ways to reduce their asthma, having a risk of an asthma flare-up. And what are some ways that they can reduce that? Let's say you have a patient with asthma and you ask them these subjective questions, and now they said, oh, I live somewhere with a lot of dust, for example. What are some things that they can do to modify their environment to prevent them from having those asthma flare-ups? Maybe vacuum more frequently, right? Change air filters, yes. Maybe they live somewhere that there's a lot of air pollution and that's what's triggering their allergies or their asthma. Maybe they need to wear a mask in those areas. Or maybe, for example, they have a certain position or occupation. Maybe they need to wear a mask for their job so that they're not exposed to those chemicals or pesticides, things like that. Let's say a farmer or a coal miner, right? Maybe you want to encourage them or teach them that they should wear a mask while they're at their employment. Okay. And this is talking about the rationale of why we're assessing this in our patient. We want to help calculate by asking them about the packs per day, how many packs per day they're smoking. It helps us to calculate the risk of developing lung cancer or other pathologies related to tobacco use. Okay, and this is what we just talked about also. And the environmental considerations. Certain people who work in different occupations are at risk of developing respiratory conditions. For example, coal miners are at risk for developing silicosis from exposure to coal dust. So that's why educating them on ways that they can reduce their exposure to these environmental agents is important. Okay, now that we got through the subjective part, we're going to go through the objective assessment. So the first thing that you want to do when you do a objective assessment is inspection. So what are some things or some questions that you can do to perform an objective assessment? Any masses or discoloration is good, yes. You want to look at the thoracic cage, at their respiratory pattern, how they're breathing, and the quality of respirations. You want to look at their skin color and their condition. First, we just mentioned that, with see if there's any masses or skin color changes. Maybe, for example, they're having cyanosis and their skin is turning blue. That would indicate hypoxia. Any accessory muscles used for breathing, right? These are things that we can visually inspect on our patients. The patient's position, their facial expression, and their level of consciousness. So an expected finding, we're going to go through what you would expect and what would be an abnormal finding in all of these 6 different categories that we're going to inspect. So for the thoracic cage, an expected finding would be an anterior-posterior diameter of 1 to 2 or 0.70, right? This is an expected finding. An abnormal finding, for example, would be an increased AP diameter. And in what patients might we see this increased AP diameter? Barrel chest, that's what it's called, yes. And we see it in people with COPD, right, exactly. So this is an abnormal finding. Mostly seen in patients with chronic emphysema and asthma as a result of hyperinflation of the lungs. With emphysema, there's air trapping, the lungs can't get out, and it's increasing their AP diameter. Good. Another abnormal finding that we might see is pectus excavatum, and that's a shrunken sternum. It's congenital and usually asymptomatic. So their sternum is actually kind of sunken in. Another abnormal finding is a pigeon breast, or pectus keratinum. It's a forward protrusion, unlike the funnel breast that we just talked about. This is going in the opposite direction. It's actually a protrusion of the sternum. It's a minor deformity requiring treatment. Another thing that we might, abnormal finding we might see in inspection in our respiratory patients is scoliosis, right? It's a lateral S-shaped curvature of the thoracic and lumbar spine with unequal shoulder and scapula height and unequal hip levels. If mild, the patient might not have symptoms, but if severe, the scoliosis can actually reduce the lung volume, how much air patients are able to breathe in and breathe out. Okay, so let's move on. Kyphosis, another abnormal finding, is a curvature of the posterior spine. What might we see kyphosis in? What age group? Elderly, right? It's associated with aging and especially seen in postmenopausal osteoporosis. Good. The next thing that we want to assess, right, we're doing the inspection of our objective assessment of our patient with respiratory conditions. We're going to look at the respiratory pattern and the quality of the respirations. So what is a normal respiratory rate? $12 to $20, yes, 12 to 20. It should be 12. With an even pattern and depth. Good. What's tachypnea? Accelerate breathing fast and deep, exactly. Ticking, this first part means fast, and the second part of the word is breathing, so it's fast breathing. It's rapid, shallow breathing with an increased rate, usually greater than 24 breaths per minute. It's expected in when patients have fevers, they'll have tachypnea. If they're in pain, if they have anxiety, or if they just exercised. Some other causes of tachypnea might be respiratory insufficiency, pneumonia, alkalosis, which causes a low CO2, or a lesion in the pons, because the respiratory center is located in the pons. So if they're having, for example, a brain tumor maybe, or they had a traumatic brain injury and the pons affected, that might cause the patient to have rapid breathing. Fast and deep would be small. We're going to talk about that in a second, Kimberly. Tachypnea is rapid shallow breathing with an increased rate. Fast and deep would be small, you're right. Okay, so rapid and shallow is tachypnea with an increased rate greater than 24. Some causes of tachypnea are this below. An abnormal finding again would be bradypnea. And what is bradypnea? What would the respiratory rate be? Under 12, yes. Less than 12, yes. What are some causes? Can you guys tell me why the patient might have slow breathing? Overdose, right? Maybe they took too many narcotics. Increased intracranial pressure can cause slow breathing, and diabetic coma can cause slow breathing. What else, Jessica? I see you typing. Old age? Maybe. They're older, they may have that kyphosis like we talked about. It's affecting their the volume that they can breathe in. Perhaps they might have that. Maybe they have muscular weakness from old age. What's hypoventilation? Is what normal, Stephanie? The slow breathing normal? I'm not sure. I have to find out for you. I haven't heard of that before, but I can definitely find out and send you an email. How about hypoventilation? What does that mean? It's irregular and shallow, slow breathing, right? Again, might be caused by overdose of narcotics or anesthesia or prolonged bed rest. It differs from bradypnea because bradypnea is a decrease, but it's regular. Hypoventilation is irregular. And Cheney strokes respirations. Can anyone tell me what those are? It does have to do with, sometimes they'll have breathing periods of 30 to 45 seconds with periods of apnea lasting up to 20 seconds. So it does have to do, they do periodically have short pauses in their breathing. Normally it occurs in infants and adults during sleep, but other causes can be heart failure, renal failure, meningitis, drug overdose, and increased ICP. Okay. Hyperventilation. So what is this? Can you guys tell me? Someone said it before with the small breathing, I think Kimberly. It's an increased rate and depth. So that's how it differs from tachypnea. Remember with tachypnea, it's a regular kind of rhythm. This is increased rate and depth with hyperventilation. Someone who is very anxious, for example, maybe they're having an anxiety attack, or they just exercised a lot, you would expect this. But other causes might be diabetic ketoacidosis, in which case you would see the Kussmaul's respirations, or alterations in arterial gases. An increase in CO2 will stimulate hyperventilation so that the body can breathe off excess CO2. So if the CO2 is high, the patient will hyperventilate to get off the excess CO2. With hyperventilation, the body breathes off the CO2 and the patient can become alkalotic or have a high arterial pH. The next thing that we want to assess is the quality of the respirations. So an expected finding would be relaxed, automatic, and effortless. It would produce no noise, it would be even and symmetric, and there should be no retractions that occur of the interspaces, and no accessory muscle use. Abnormal finding would be noisy breathing, which can occur in patients with COPD or asthma. They might have unequal chest expansion, which occurs when part of the lung is obstructed. They might have retractions, which suggest obstruction of the respiratory tract, or that increased inspiratory effort is needed, as with atelectasis. They also might be using accessory muscles, for example, if they have an acute airway obstruction, and they might be having abdominal and intercostal muscle use if they're having to force their expirations, as in COPD. The next thing that we're going to assess is the skin color and condition. The color should be, an expected finding is that the color should be consistent with the person's genetic background. An abnormal finding might be cyanosis, right, which could indicate hypoxia, or their mucous membranes might be pale. They might have clubbing of their fingernails, which is seen in COPD. Position, right? We're going to assess how they're sitting. They should be relaxed and able to support their own weight with arms comfortably at the side. But if they're, for example, in a tripod position, if they're leaning forward with their arms braced against their knees, against the chair, against the bed, they might be having COPD, because this is often seen in people with COPD in the tripod position, because it helps them to breathe better. They're using their accessory muscles by leaning over to assist in their breathing. And then you want to look at their facial expression. Are they relaxed, or are they tense? Are they tired? Are they using pursed lip breathing? And that's what is pursed lip breathing? It's when the lips are in a whistling position, pursed lip breathing. And then you want to assess their level of consciousness. So what is something that you might see in a patient who is having difficulty breathing? Let's see. Yes, pursed lip breathing is seen in COPD patients. What about their level of consciousness? What are some things that you might see in a patient who's having difficulty breathing? What might you see with their level of consciousness? What would be an abnormal finding? We would expect them to be awake and alert and oriented, but if they're having difficulty breathing, if they're not getting enough oxygen, what might happen to their level of consciousness? Decrease impaired, yes. Restless, lethargic, and confused. And why would they be confused? Why would that be happening? Not getting confused, exactly, Andrea. The brain is not getting oxygen. The changes in level of consciousness, like the confusion, the anxiety, the drowsiness, maybe the restless, it happens as a result of cerebral hypoxia. The next thing we're going to do is palpation. So the first objective part of our assessment was inspection. The second part is palpation. So to palpate, we're going to confirm symmetric expansion, we're going to assess tactile firmness, and we're going to palpate to detect any lumps, masses, or tenderness. Some abnormal findings that we might see when we're assessing these things is crepitus. Crepitus is a coarse crackling sensation that you feel over the skin surface. and it's a result of subcutaneous emphysema as air escapes from the lung and enters subcutaneous tissue. It's especially common after open thoracic surgery. So to confirm symmetric expansion, this is how we perform the assessment. So kind of like we see in this picture here, to do this on the posterior chest wall, we're going to place our thumbs together at the level of T9 or T10, and anteriorly we place our hands, the thumbs pointing to the exophoid process, just like this picture is showing. You slide your hands medially to pinch up a small fold of skin and ask the person to take a deep breath. Then you watch for symmetric movement of your thumbs. It's usually easier to assess on the anterior chest wall than it is on the posterior chest wall because it's easier to see the range of motion of the breathing. An expected finding is that as the person inhales deeply, the thumbs move apart symmetrically, but an abnormal finding would be unequal chest expansion. And what are some reasons that might occur? Exactly, pneumothorax. What else? Pleural effusions, right? Or maybe pneumonia or thoracic trauma. Pneumonia, good. Good. Tactile firmness. Can you guys tell me what that is? Yes, Hermione. And why are you asking them, what are you feeling for? Vibrations, right? That's why we're asking them to say 99. The intensity of the vibrations, yep. Yes. So it's a palpable vibration that's generated from the larynx and through the bronchi and lung parenchyma to the chest wall. Yes. And exactly like you said, you're going to use your palm to touch a person's chest while he or she repeats the words 99. You can also say good moon, because these are resonant phrases that generate strong vibrations. Posteriorly, you start over the lung apices from one side to the other, and anteriorly, you start over the lung apices in the supraclavicular areas, avoiding femoral breast tissue, and you're palpating from one side to the other. The expected findings, like Kirsten said, is that the vibrations should be symmetrical. They should be felt the same on each side. They should feel the most prominent between the scapula and around the sternum, where the major bronchi are closest to the chest. And as you progress down the chest and as more tissue impedes the sounds, the vibrations will decrease. Firmness will also should feel greater or stronger on a thin chest wall than that on an obese or heavily muscular one. And why would you feel less vibrations on someone that's obese or has a lot of muscle? Right? That's right. They might have more tissue, right? An obese person might have more tissue that's impeding the vibrations or the sound transmission of the vibrations. So what are some abnormal findings that we might see when we're assessing the tactile firmness? It might be decreased, it might be increased. They might have bronchial firmness or pleural friction firmness. The decreased firmness would occur with an obstructed bronchus, pleural effusions, or thickening. Any barrier that prevents sound transmission would cause decreased firmness. Increased firmness might occur as a result of consolidation of lung tissue, such as lobar pneumonia. The bronchi are still patent, and the consolidation extends to the lung surface. Bronchial firmness might occur with thick bronchial secretions, and pleural friction from this might occur with inflammation of the core. Now that we inspected and we palpated, what's the next thing that we're going to do? Percuss, and then we auscultate Kirsten. So percussion. So how we're going to perform percussion on the posterior lung is using the middle finger to tap on the lungs, starting at the apices. Then we're percussing the bands of normally resonant tissue across both of the shoulders. We percuss in the interspaces, making a side-to-side comparison, and move all the way down the lung region. We assess this anteriorly by starting at the apices and the supraclavicular areas, and then percuss the interspaces compared side by side. And usually the interspaces are easier to palpate on the anterior chest than on the back. That's the zigzag motion, Hermione? I'm not sure. I'll find out if it's more than a zigzag motion for you. Usually go from each side down, across to the other side, down, and then across to the other side. There's actually a picture in your book on page 425 that shows the direction of the percussion. So if you want to look in your books, page 425, it shows the direction of how to percuss. Expected findings. What are expected findings when we're percussing? Resonance, exactly, yep. We want resonance, a low-pitched, hollow sound that predominates in the healthy lung tissues of the adult. What are some abnormal findings? Hyperresonance, yes. And why might they have hyperresonance, Kim? Too much air. Hyperresonance occurs when there's too much air as an emphysema and it's a low-pitched booming sound. If they have a dull sound, it might be because of an abnormal density in the lungs, as what occurs with pneumonia, pleural effusion, atelectasis, or a tumor. So that it will be dull if they have a tumor, pneumonia, pleural effusion, or they'll have hyperresonance as a result of air trapping, like what happens in emphysema, COPD. Okay. Now, last but not least, is hyperresonance normal in children? I'll find out for you, Taylor, about in children. And I can email you. There is a page in your book, again, 427, and it shows, it goes over the developmental competence, and it goes over infants and children and what would be expected findings in the infants and in that population of patients. I'm just not sure. I have to read up a little bit more. I'm not a pediatric nurse, so I'm just not used to assessing those kinds of patients. But I will find out for you. So next but not least is auscultation. So how do we assess that? What instrument are we using? Stethoscope. Posteriorly, we're starting at the apices, working downward towards C7 and then to the bases. Anteriorly, we're starting at the apices in the supraclavicular areas, and we're working our way down to the sixth line. So what are normal breath sounds that we would expect in our patient? So we would expect bronchial, bronchovesicular, and vesicular breath sounds. And what is the bronchial breath sound? Bronchial breath sounds are heard more at the trachea and larynx, more on expiration, and they have a harsh, hollow tubular sound. Bronchovesicular are heard over the major bronchi, where fewer alveoli are located, and vesicular are heard over small peripheral lung fields, where air flows through smaller bronchioles and alveoli. It makes a rustling sound that is heard better on inspiration than expiration. You just want to make sure that when you're assessing your patients, that you're making sure that any external noise is not interfering with what you're hearing. So for example, if the patient is listening to their TV, if there's rustling of their clothes that might interfere, you want to eliminate those noises that could interfere with your assessment. What are some abnormal breath sounds? Can you guys tell me what are some examples of abnormal breath sounds? Stridor, wheezing, crackles, rales bronchi, wheezing, good. So decreased breath sounds is anything that obstructs transmission of sound between the lung and your stethoscope, such as fluid or air in the pleural space. It indicates an obstruction of the bronchial tree by secretions, mucus plug, or foreign body. It also occurs in emphysema due to the decreased force of inspired air, a result of a loss of elasticity. Another thing that you might hear are increased breath sounds, and those are sounds that are louder than they should be. They occur with consolidation or compression, and they yield a dense lung area that enhances the transmission of sound from the bronchi. These might occur with fluid in the interpleural space. Fine crackles, like Stephanie said, they're short, crackling, popping sounds heard during inspiration, and they are not cleared by coughing. They're occurring because inhaled air collides with previously deflated airways. If they occur late in the inspiratory phase, they're usually from restrictive diseases, whereas if they're occurring early in the inspiratory phase, they're usually a result of COPD. They can be posturally induced or heard when a patient changes position. Hoarse crackles are loud, low-pitched bubbling or gurgling noises, and they occur because inhaled air collides with secretions. What are some reasons why a patient might have hoarse crackles? Cystic fibrosis. What else? What are some other reasons? Fluid accumulation in the lungs, right? Maybe from pulmonary edema, right? Maybe the patient has left side of heart failure and the fluid is backing up into the lungs, causing pulmonary edema, and this is causing them to have those crackles. They might have pulmonary fibrosis, pneumonia, or they might be terminally ill and have a decreased cough reflex. What's a pleural fiction rub and why is that happening? Can you guys tell me? Yes, one. It's happening because of inflammation of the pleura, and those two pleural surfaces are actually rubbing together because there's a loss of lubricative fluid. Rubbing of the pleural fissura, yes. It's due to pleuritis, and it's associated with pleuritic pain. When you hear this in your patients, it's going to sound like two pieces of leather are rubbing together. How about wheezes? What kind of patients might have wheezing? Asthma, yep, asthma. Asthma. What else? COPD, emphysema. And why is this happening? It's from inflammation of the airways, Kirsten. Inflammation of the airways and narrowing of the bronchioles. Air is squeezing through compressed passageways from swelling, secretions, or tumors, and it sounds like a squeaking. There's high-pitched and there's low-pitched. Low-pitched has more of a snoring sound and are more prominent on expiration than they are during the inspiratory phases. Airflow obstruction usually generates this sound, and it's due to obstruction from an airway tumor. Stridor. What's stridor? Can you guys tell me? Why might a patient be having stridor? Upper airway obstruction, yes. So this is actually a life-threatening condition. Can be also due to croup or acute epiglottis, but it's usually indicative of an upper airway obstruction from swollen inflamed tissues or from a foreign body. It occurs during inspiration and it's a high-pitched crowing sound. Good. So someone was asking earlier about the hyperresonance in children. These are some other things that you might assess in younger patients, and some things that you might want to do during their assessment. What are some things that you would want to do? Maybe to decrease the child's fear. Maybe you want to get the parents involved, let the child sit on the parent's lap during the assessment. Maybe you want to let them use your stethoscope so that it reduces their fear or their anxiety during the exam. And what's another expected finding that we would see in infants and children? What about their respiratory rate? Would it be faster than it would be in the adult or slower? Yes, it would be faster. Children usually have respiratory rates of 30 to 40 breaths per minute that may go as high as 60. How about in the pregnant woman? What is a normal finding in the pregnant woman? What are some symptoms that a pregnant woman might be complaining of, especially during her third trimester? Yes, they do have deeper respirations. The thoracic cage widens by about 50%, and the respirations are deeper with an increase in tidal volume. They do have shortness of breath as well because the diaphragm is pushed up. So especially during the third trimester, mild shortness of breath is common. What about in the older adults? What's something that we might see? Yes, we would. The older adults may have difficulty breathing off, so you would see an increased residual volume. There might be increased volume inside of the lungs. Barrel chest, along with kyphosis, chest expansion may be decreased. The coastal cartilages become calcified, which results in a less mobile thorax, and they may tire easily with deep breathing when auscultation is required. So you want to make sure when you're assessing these patients that they don't hyperventilate as you're assessing them. So you would want to make sure that they're not getting dizzy or anything like that. Okay, so we're going to do some ABGs. So with arterial blood gases, there's 4 disorders that can occur: metabolic acidosis, respiratory acidosis, metabolic alkalosis, and and respiratory alkalosis. So what is acidosis versus alkalosis? With acidosis, the pH would be what? High or low? Right. With acidosis, we would expect a low pH. Versus alkalosis, what would the pH be? Right. pH would be high. It would be greater than 7.45. And the normal pH is what? Yes. 7.35, 7.45. Mm-hmm. So acidosis is the presence of a condition that tends to decrease the pH of the blood, making it more acidic. And acid increases the blood concentration of hydrogen ions. So when a patient is acidic, they have more hydrogen ion concentration in their blood. Alkalosis is the presence of a factor that increases the pH of the blood, making it more alkaline or basic. A base neutralizes the acidity. Bicarbonate ions are a type of base. Okay, so we have a question. You guys can tell me which ones you think it is, and then I'll put the submit button for you. ABGs are regulated by what 3 mechanisms? Buffers, the respiratory system, neurologic, and renal system. This is going to be a select all that apply. Yes, Andrea, it's buffers, the respiratory system, and the renal system. So what is a buffer? The buffer is the bicarbonate buffer system. If too much acid is present, for example, lactic acid, bicarbonate ions take up the hydrogen ions released by the acid and turn it into carbonic acid. Then through the action of carbonic anhydrase, the carbonic acid is excreted by the respiratory system as carbon dioxide and water. The renal system is slow acting. It can excrete any acid but carbonic acid or CO2. If a metabolic acid accumulates in the blood, there will be more excretion by the kidneys. If a metabolic acid is deficient in the blood, it will lead to slowed excretion to allow accumulation. The renal system also uses urine buffers like ammonia. And the respiratory system works the fastest. CO2 and water make carbonic acid, and through respiration, the lungs excrete CO2 from the body. The lungs adjust the amount of acid that remains in the body by altering the rate and depth of breathing. If too much acid accumulates, the lungs increase the respiratory rate to remove excess acid. If too little acid is present, the lungs slow down breathing to increase the acid levels. PaO2 shows how well the respiratory is excreting the carbonic acid. If PaO2 is elevated, too much carbonic acid is in the lungs, and the respiratory system was not able to remove it, perhaps due to an underlying disease. Only the lungs can excrete carbonic acid, and other acids cannot be removed by the lungs, such as lactic acid, which leads to compensation. The lungs will secrete carbonic acid in the presence of another acid in the blood, which adjusts the pH and keeps it from dropping too low. So let's start with metabolic acidosis. What are some reasons why a patient might have metabolic acidosis? What are some causes? body doesn't break down carbonic acid to bicarb. Carbonic acid is water and CO2, so Andrea, don't think, no, it does not break it down to bicarbonate. So anything that causes an increase in acids or an excessive removal of a base. For example, diarrhea might cause metabolic acidosis because the intestinal fluid is rich in bicarbonate ions, which are a base. So if the patient has a lot of diarrhea, they're losing all of those bicarbonate ions, which leads to the acidosis because they're losing an excessive amount of the base. Another thing that can cause metabolic acidosis is diabetic ketoacidosis, usually from type 1 diabetes because of the lack of insulin. Because of the lack of insulin, glucose cannot get into the cell. The cells start to starve, and the body starts to break down ketone bodies as an energy source, which increases the amount of acid and leads to acidosis. What are some things that you might see in a person with metabolic acidosis? Confusion, right? They might be confused. You would see mental status changes, lethargy, stupor, coma, and these CNS effects are due to increased pH of cerebrospinal fluid and interstitial fluid. So if the ABG is uncompensated, what might you see? Uncompensated ABG in a person with metabolic acidosis. They're acidotic, right? So their pH will be high or low. Low, right? We're talking about uncompensated ABG in a person with metabolic acidosis. They'll have low pH because they're acidotic. And what else will be low? Bicarb, right? Because this is primarily a metabolic disorder, and bicarbonate is excreted by the kidneys. So you expect the uncompensated ABG to have a low bicarbonate, low pH, and normal PaCO2 because this is not a respiratory disorder. It's metabolic in origin. What about a compensated ABG? What will the body do to compensate in metabolic acidosis? What is the body doing to compensate in metabolic acidosis? Hyperventilation, yes, Kimberly. Hyperventilation will cause increased excretion of the carbonic acid, which is the CO2 in water, by the lungs. So we just went over this. What do the lungs do to compensate for metabolic acidosis? Hyperventilation, right? Hyperventilation will cause increased excretion of carbonic acid by the lungs, which is CO2 in water. So what's respiratory acidosis? Will the pH be high or low? Oh, right. And what causes it? What are some things that might cause respiratory acidosis? Right, hypoventilation because we would be retaining the CO2. So anything that causes an excess of carbonic acid. underlying respiratory conditions that prevent removal of carbonic acid from the lungs. Yes, Andrea, drugs that can cause respiratory depression. Respiratory depressant drugs that might impair respiratory control in the brainstem can cause respiratory acidosis. Maybe they also have a neuromuscular condition that's causing respiratory muscle fatigue, and their lungs are not able to breathe off the CO2, so they're retaining it. Another example might cause acidosis is COPD, because there's impaired gas exchange. So what would we see in uncompensated ABG in a patient with respiratory acidosis? Would the pH be low or high? Low, right? And how about the CO2? Would we expect to be low or high? Right. And how about the bicarbonate? Would be normal or low? Right, exactly. So what are some things that we would see in compensated ABG? Instead of having a low bicarbonate, when it's or normal bicarbonate because it's uncompensated, we would see an increased bicarbonate because that's when the compensation in the kidneys are starting to get involved. So there would be an increased PaCO2, increased bicarbonate, and a lower normal pH depending on the degree of compensation. And what are the kidneys doing to compensate for respiratory acidosis? Excreting acids, right? They're excreting the hydrogen ions and they're retaining the bicarbonate to neutralize the acidity. Good. But these effects, remember, are very slow, so it might not correct it immediately. What about metabolic alkalosis? What are some things that cause it? Some things that might cause metabolic alkalosis. Right, a lot of vomiting. Maybe the patient has is vomiting a lot. Maybe they have a condition like maybe they have an obstruction or something, and they're vomiting. They have hyperemesis because they're losing those stomach acids, right? And all the acids are being lost in the vomit. Maybe they're taking a lot of bicarbonate medications or antacid medications. Also, patients with hyperaldosterone would have metabolic alkalosis. Hyperaldosterone causes sodium and water reabsorption by the kidneys, potassium excretion, and causes more hydrogen ions to be excreted into the urine. So with hyperaldosteronism, there's an excessive loss of hydrogen ions in the urine. And when there's too much aldosterone, the blood will become more basic. Some other things that we might see this in is hypokalemia, right? The levels of hydrogen ions are low in the blood and the pH is too high, and the body is trying to fix this by moving the hydrogen ions out of the cell. And as a result, when the hydrogen ions move out of the cell, there's a shift of potassium into the cell, which results in low levels of potassium in the blood. Does that make sense? So hypokalemia can be a cause and a result of metabolic alkalosis. What are some things that you might see in a patient with metabolic alkalosis? What are some signs and symptoms that you might assess? When patients have metabolic alkalosis, they also have hypocalcemia because alkalosis causes more calcium to bind to albumin in the blood, so there's less free calcium because it's bound to albumin. So there's hypocalcemia. So what are some signs and symptoms that you might see from the hypocalcemia? Tetany, yes. Neuromuscular excitability, right? When you think of hypocalcemia, they might have spasms, seizures. And how can you I'm not sure, Chris. I'll have to find out for you. Hypocalcemia, you would see a lot of neuromuscular irritability. But how are some ways that we can assess this? You guys know what the Chvostek sign is? Yes, that's where you tap on the cheek and you're assessing their facial nerve and the cheek twitches. And this can happen as a result of hypocalcemia. How about Trausu's sign? Trausu's sign is when you inflate a blood pressure cuff on their arm, and then there's a spasm of their wrist from the inflation of the blood pressure cuff. So cheek twitching is abnormal, but a positive Trausu's sign. Cheek twitching is abnormal. Andrea, I'm not exactly sure what you're asking. Cheek twitching is abnormal, and it means that they have a positive Trausu's sign. They shouldn't, when you tap their facial nerve, there shouldn't be that reaction. They shouldn't have that twitching of their face. They're having that twitching from the neuromuscular excitability as a result of the hypocalcemia. Is it considered positive for sign? Yes. So the Trausu's sign is positive when you tap their facial nerve and they have that cheek spasm. Yes. Okay, good. And the Trausu's sign is the other way that you can assess hypocalcemia. What might you see in a patient with hypokalemia? Cardiac dysrhythmias, right? That's the big thing with hypokalemia. And you might also see muscle weakness. So what would be an uncompensated ABG in a person with metabolic alkalosis? What do you guys think? Would the pH be high or low in alkalosis? High, right? They're alkalotic. There's too much base. They have a high pH. Would the PaCO2 be normal, high, or low? CO2, normal, high, or low in uncompensated metabolic alkalosis? CO2 would be normal, right? Because the underlying condition is not respiratory, it's metabolic. Yes, exactly, Kimberly, thank you. And the bicarbonate will be high or low? Uncompensated, good, yes, Jennifer, thank you. So if there is compensation in metabolic alkalosis, how will the body do that, and what are some things that we would see in the ABG? Would the lungs hyper or hypoventilate? Compensation means normal pH. Yes, compensation means that the body is trying to fix the issue and is trying to get the pH back to normal. If it was fully compensated, the pH would be completely normal. But with this, the way that the body is compensating for metabolic alkalosis is, right, Kimberly, is with hypoventilation. And usually the compensation is incomplete, so the pH will not be completely normal because we need oxygen, and the need for our oxygen drives our respiratory rate. Okay, so in a compensated ABG with metabolic alkalosis, we would see increased bicarbonate, increased CO2, and slightly increased pH. Oh, I'm so glad. Okay, I'm glad this is helping. Okay, so how about we do this question then? This is about labs. So what is the normal potassium level? .5 to 5. Yep, so that this would be go here. And what other electrolyte imbalances would you see in a person with metabolic alkalosis? You would see hypocalcemia, right? And that's because alkalosis makes the calcium bind to albumin in the body. So there's less free bound calcium. So there's hypocalcemia with metabolic alkalosis. What other electrolyte imbalance is there? Hypokalemia, yes. And why? Do you guys remember why that is? As a way that our body tries to compensate for the hydrogen, there's actually a shift of the hydrogen into the cell, and hydrogen out of the cell, and potassium. Wait, I'm saying this backwards. Hold on, I'm confusing myself. Yes, pushes K into the cell. There's a shift of hydrogen out of the cell, into the cell, and potassium out of the cell. That's what I was saying. I'm trying to say. So there'll be hypokalemia. Okay, so what is hypocalcemia? You guys know the normal level of calcium? Calcium normal levels are 8.5 to 10.2. So what is hypocalcemia? It will be less than what? Less than 8.5, right? So other electrolyte imbalances that you will see in metabolic acidosis are hypokalemia, and hypocalcemia is calcium less than 8.5. Okay. And how will the lungs compensate in metabolic alkalosis? What's the answer, guys? Hypoventilation, right? Because there's too much base, so the body is decreasing the respirations to try and retain the CO2 to balance out all of the base. But usually this is incomplete, right? Because we need the oxygen. It drives us to breathe. Does this make sense so far? Okay, so we're going to move on to respiratory alkalosis, and then we have just a couple of case studies that we'll go through. Okay? So what causes respiratory alkalosis? Anything that might cause a decrease in the CO2, or the carbonic acid. And something that might, as an example, cause it is hyperventilation, because there's too much CO2 that's being breathed off. So what would you see in an uncompensated ABG in someone with respiratory alkalosis? Will the pH be high or low? We're talking alkalosis. High, right? Alkalosis means high pH. Acidosis means low pH. That's okay. And what about the bicarbonate? Will that be high or low? Actually, this would be normal because it's uncompensated. I think this was a typo. And what about the CO2 in respiratory alkalosis? Low, right? And how are the kidneys compensating? Remember, it's alkalosis, so there's not enough acid. So they compensate by retaining acid. They prevent the excretion of hydrogen ions. And instead, they're going to excrete bicarbonate ions. So what would we see in a compensated ABG? Would the pH be high or low? It might still be high, right? Because our bodies might not be able to fully compensate. And how about the bicarbonate now? When it was uncompensated, it was normal, but now that the kidneys are getting involved and they're starting to help compensate, it would go lower, right? Because the kidneys are excreting the bicarbonate. Good. So what would be an expected finding in this patient? Neuromuscular excitability, increased heart rate, decreased heart rate, or alkalosis leads to less calcium and neuromuscular excitability. This one is going to be 2 answers. Increased excitability, right? Because alkalosis leads to hypocalcemia. And what's the normal values of calcium again? I think it's 8.5 to 10.2. It does vary based on the lab that each, hospital uses. It might vary slightly, but I think it's 8.5 to 10.2. And there's one more answer here. There's one more answer. So what do you think the last answer is here? The last one, right? Alkalosis leads to hypocalcemia and neuromuscular excitability. Good. Okay, so now we're just going to recap the steps. Okay, so step 1. There's supposed to be arrows here, but they got typed out really weird, so I'm sorry about that. But if step 1 is to look at the pH. If the pH is less than 7.35, it leads to acidosis. If it's greater than 7.45, what will it be? Greater than 7.45, acidosis or alkalosis? Alkalosis. Okay, then step 2. Now that we looked at the pH and we determined what the pH is, now we go on to step 2. We have to figure out which one is in the expected range. If the imbalance is with the PaCO2, the condition is what? Respiratory or metabolic if CO2 is off? Respiratory, right? And then if the imbalance is with the bicarbonate, is it respiratory or metabolic? Good. So step 1, we're figuring out the pH. Step 2, we're figuring out what the imbalance is. Is it with the CO2 and is it respiratory, or is it with the bicarbonate and or is it metabolic? Okay, and then step 3, we're going to determine the compensation. If it's uncompensated, the pH will be outside the expected reference range, and either the CO2 or the bicarbonate will be abnormal. So uncompensated pH will be abnormal, and either CO2 or bicarbonate will be abnormal. It's not both. If it's partially compensated, the pH, the bicarbonate, and the CO2 will be outside the expected reference range. If it's fully compensated, the pH will be normal, but the bicarbonate and the CO2 will be abnormal. Does that make sense? So let's do a case study. We're a nurse working evenings in an ICU. Several hours into your shift, you receive a call from a nurse on a medical surgical unit advising you of a transfer to your ICU. Mary Murata is an obese, 42-year-old female who had an open cholecystectomy 3 days ago. So let's just look at this right here. She's 42, right? She's obese and she's post-op. And when patients are post-op, what are they at risk for? What are some things you might want to worry about a post-op patient in? Infection, yes, that's true. Yep. What falls there? Yeah, that's true too. Bleeding. Breathing, right? Maybe they were under anesthesia, so they might have respiratory depression. Yes, they might get constipated. They might have decreased peristalsis. Another thing that patients are at risk for is blood clots post-op. So just keep that in mind as we go forward. Okay, and another thing, one more thing? I think that one more thing that we didn't mention was urinary retention. As a result of the anesthesia might cause urinary retention. Okay. Other than obesity and gallbladder disease, Ms. Murata past medical history is unremarkable. She takes Claritin for seasonal allergies and is on an oral contraceptive. So what else is putting her at risk for a clot here? Yes. Birth control, hormones, estrogen, those things increase the risk for developing a blood clot or DVT. Okay? However, Ms. Murata's post-op recovery has been difficult. Despite encouragement and other nursing measures to alleviate pain, Ms. Murata has been reluctant to get out of bed, ambulate, and use her extended spirometer. So, approximately 30 minutes ago, Ms. Murata became restless and complained of sharp chest pain and chest wall tenderness and shortness of breath. A pulmonary embolism is suspected. ABGs have been drawn, a 12-lead EKG to rule out angina or MI, and a chest X-ray to rule out pneumonia and pneumothorax have been done. So which of the following statements best characterizes the pathophysiological changes that occur with PE? Is it obstruction of the pulmonary arterial blood flow occurs, resulting in pulmonary hypertension and hypoxemia? Obstruction of pulmonary venous blood flow occurs, resulting into backflow of blood into alveoli and hypoxemia? Or left ventricular failure causes accumulation of fluid in the lungs, resulting in hypoxemia? I'll let you guys take a couple minutes to pick the answer. What do you guys think? 1, 2, or 3? One, I think 2 maybe. 2. Okay, so let's see. The answers are the correct answer is the first one. Obstruction of pulmonary arterial blood flow occurs, resulting in pulmonary hypertension and hypoxemia. The reason that happens is because when there's a blood clot in the lung, there's pulmonary vasoconstriction and pulmonary hypertension, which then causes the hypoxemia. So the correct answer is 1. So the number, it might not be 2 because obstruction of pulmonary veins blood flow occurs resulting in backflow, but it's alveoli and hypoxemia. It's not 2 because there's not backflow of blood. There's actually vasoconstriction, which is causing the hypertension. So that's why it's number 1. And it's not number 3 because that's what happens actually with heart failure. The left side of the heart fails and the blood backflows into the heart, and the fluid will accumulate and result in hypoxemia. That's a result of heart failure, left ventricular heart failure. But with pulmonary embolus, what exactly is happening is that there's pulmonary vasoconstriction because the arteries are trying to divert the blood to areas of the lung that have better oxygenation. So they vasoconstrict the alveoli that have poor ventilation, and they divert it to areas that have better ventilation. But that vasoconstriction in the lungs causes pulmonary hypertension, and the pulmonary hypertension causes increased afterload for the right side of the heart. Remember, because the right side of the heart is sending the blood to the lungs. So actually there's right-sided heart failure first. Does that make sense a little bit more? Yes, okay, good. So pulmonary vasoconstriction occurs. Then there's pulmonary hypertension. There's increased workload of the right side of the heart, not the left side. Yeah, so you have to think of the flow of the blood. I think that will help you if you think about the flow of the blood from the sides of the heart and where it's backflowing into. The blood in the lung is coming from the right side of the heart to get oxygenated. So that might help you in thinking about the signs and symptoms. Okay, and the left side of the heart sends the blood out to the systemic circulation to the bottom. Right side circulates. So when there's pulmonary hypertension, there's increased workload on the right side of the heart. Okay, so let's move on to the next part. With a PE, alveoli in the affected area are ventilated but not perfused. Affected areas are described as dead space, fibrotic, or hyperinflated. So what do you guys think? 1, 2, or 3? One, yes, Kimberly. Why would it not be hyperinflated? Why would it not be 3? It's because they're not getting ventilation, right? So when lungs, when alveoli are hyperinflated, there's too much oxygen in them. but here they're not getting ventilated. So there's dead space. Exactly. So let's just double check 2. 2 is A, yep. So 3. Given the pathophysiology of PE, which of the following should be done first if a patient at risk for PE complains of chest pain and shortness of breath? So this is a priority question. It's asking, as a nurse, what should you do first for a patient at risk of PE? If they start complaining of symptoms, they become symptomatic. The first thing that you want to do, take their vital signs, position the patient for optimal ventilation, call the physician, connect the patient to a cardiac monitor, or D, apply oxygen. What do you guys think? First thing. Two, yes. And what would be the best position to have this patient in? Answers 2. What you should do is just elevate their head of the bed. So elevating the head of the bed will be the best way for the lungs to get optimal ventilation, just elevating the head of the bed. Sit the patient up, right? It helps the lungs to expand the best in that position. Okay. What may be the next thing that you want to do? After you you elevate their head of the bed, what are you going to do next? Vitals. Yes, Kimberly, right? You would take their vitals. You want to see if they're, what would you want to check especially? Which vital sign would be important in a patient with PE? O2 sat, right? You want to make sure that they're getting adequate perfusion. And if their O2 sat is low, what would it be? Less than what? Yes. Yep. Less than 90. Yep. In which case, that's when you would do this step. That would be the next one. Yep. Good. So, okay, let's do the next one. All right, so now we're going to do these ABGs questions, okay? Ms. Murata's ABG results are available. ABG results reflect, so let's look at this. pH is 7.50, so is that high or low? High, right? So do they have acidosis or alkalosis? Alkalosis, right? So automatically we can take off which 2 answers? One and 3, right? It's not acidosis because the pH is high. So it's definitely not 1 or 3. So now we're down to 2 and 4. Andrew thinks it's 2. Okay, let's see. The CO2 is 32. So what should the normal CO2 be? (35 to 45), right? So what is the CO2? High or low? Low. So do they have hypercapnia or hypocapnia? Hypo, right? So already we know the answer's 2, right? Because they have hypocapnia and alkalosis. Right, so it will be 2. But what else? How else do we know? Because look at the PaO2. It's 60. What should the PaO2 be? Yes, Andrea. So she's hypoxemic, right? Because her PaO2 is high or low? Oh, good. So which ABG would you think, what would her ABG result be? If we were going to say, is it compensated or uncompensated? It's uncompensated, right? Because the bicarbonate is normal, 22 to 26. So there's no compensation yet, right? Okay, good. So then there's one more case study, and then I have to go after that. Okay, so we can go through this one really quick. George Kent is a 54-year-old widower with a history of COPD and was rushed to the emergency room with increasing shortness of breath. Pyrexia. What is that? What is pyrexia? High fever, yep. Mm-hmm. Exactly. And a productive cough with yellow-green sputum. So what do we think? What would yellow-green sputum indicate? Infection, right? Yes, bacterial or viral. And he has a fever with the productive sputum. So that's signaling to us maybe he has, I don't know, maybe pneumonia, something, an infectious etiology. He has difficulty communicating because of his inability to complete a sentence. One of his sons, Jacob, says he has been unwell for 3 days. Upon examination, he has crackles and wheezes in the lower lobes, his tachycardia, and a bounding pulse. What's tachycardia, guys? High heart rate, yeah. Millennia. Yes, heart rate, right? So tachycardia is high heart rate. What is it greater than? 100, yep, exactly. So he's tachycardic, he has this green yellow sputum, he has a fever, so George is not looking too good. Measurement of ABG shows pH of 7.3, so pH, is that high or low? Low, right? So is he acidotic or alkalotic? Acidotic, right. Mm-hmm. So let's look at this next one. CO2, 68. What should the normal be? 35 to 45, right? So he's high or low? Yes. But wait, we didn't look at the bicarbonate yet, so we don't know. There might be compensation, right? So let's look at the bicarbonate. Bicarbonate is normally what? (22 to 26 normally, so he's a little bit high, right? So that might mean there's some compensation going on. And he has a PaO2 of 60. So what is he? What's that word when the oxygen, arterial oxygen is low? Hypoxemic. Mm-hmm. Mm-hmm. Okay, so let's answer these questions. How would you interpret this? Does he have respiratory acidosis that's uncompensated, partially compensated, or does he have metabolic alkalosis or acidosis that's uncompensated or partially compensated? What do you guys think? Partially, right? Because this pH is not fully corrected. Respiratory acidosis, partial compensation. Yep. So let's see. Yep. Correct. Patient has respiratory acidosis, indicated by the raised carbon dioxide, resulting from an acute exacerbation of COPD with partial compensation. And we know he's compensated because the bicarbonate was slightly elevated because it's trying to neutralize the acidity from the CO2. Does this make sense? So he has respiratory acidosis with partial compensation were fully compensated, the pH would be normal. Okay. So that's all I can do, guys, but I hope this was helpful. You're welcome. Good luck, everybody. You're welcome. You're welcome, guys. Hope it wasn't too boring. Good luck. You're welcome, Andrea. Good luck, everybody.